Greeting Alliance members. Please see the chat for some important instructions. In addition, please make sure to stay muted and to post your questions in the chat. We're so excited to host our first webinar for the Alliance in Cancer Care. With us today is Mr. Jeffrey Cummis. Jeffrey is RWJBarnabas Health Manager for their Epic, Healthy Planet, and Compass Rose applications. Jeffrey has an MPH in Public Health and is completing his DRPH in Public Health with a focus on social determinants of health and health equity. Jeffrey is a governance member for RWJBarnabas Health Ending Racism Together initiative, focusing on creating racial, ethnic, and cultural equity in healthcare by prioritizing these communities that are most disenfranchised and experience poor health, social, economic, and education outcomes due to generational effects of racism. Jeffrey is also a governance member for RWJBarnabas Health Equity Initiative to gain national accreditation from NCQA, developing an actionable framework for improving health equity. So without further ado, I'm going to turn this webinar over to Jeffrey.
Thank you very much, Dr. Wright, and good afternoon, everybody. Thank you for having me here today, and I'm going to discuss a little bit about what my organization has been doing to address social determinants of health for our populations. So one of the first things that we do is one of our pillars for RWJBarnabas Health is health equity and addressing social determinants of health. With that in mind, our organization decided to do two things. The first is we decided to change our EMR. We were on multiple EMRs, and we decided to change to Epic. The Epic EMR is a very robust and powerful EMR, and it also allows us to have longitudinal care visibility across all areas of a patient's journey in our healthcare organization. When we were making this change, we decided to begin standardizing our documentation. And one of the things that we decided to standardize was our social determinants of health questionnaire that we have in our system. This was done for two purposes. The first purpose was we wanted to align our documentation to be standardized across our organization, but also to meet regulatory requirements across various stewardships that we are required to report to, meaning CMS, our New Jersey Medicaid KIP program, or NCQA, as they are now finalizing quality measures that we are going to be accountable for in the future. I'll just wait a moment for the slides to catch up. So can you go back one to the enterprise? Thank you. So for our standardized tool, our organization created a social determinants of health governance committee, which had leaders from various areas of our organization. And for compliance for those regulatory needs, we agreed on the American Association of Family Practitioners approved SDOH tool that replaced our current documentation. And that is currently in place and is visible across all stratosphere of our organization. Next slide, please. So how do we collect that? We decided that SDOH should be collected at every encounter, every clinical encounter. So this is presented in our emergency room setting, in our inpatient setting for any type of inpatient visit, in our medical group office visits, and in our cancer care navigation, ACO care coordination, and our drug addiction and alcohol addiction follow-ups. So we have a large group of people that are collecting this data on a daily basis. And I think just to kind of give you an idea, I know when I looked Friday, I think we had 675,000 patients had been actually outreached. So what this does by doing the documentation in all of these areas is it brings a longitudinal visibility that allows a clinician in any area to see the most updated documentation. So there are various ways that we can present this data to our clinicians, our nurses, even our front desk folks in our Epic EMR. One of those areas is what's called the storyboard, which is on like the left-hand side of the patient's EMR. The determinants of health are there. They have color coding. So there's red for risk, green for no risk, and you can quickly access that. We have in a snapshot that gives very pertinent information for our patients, what we call our SDOH wheel, which is a wheel, and it's lit up either green or red, or it's blank if there's no data collected. And that is visible to anybody who's accessing the patient's record. Another area of longitudinal visibility is through Epic CareLink. So our organization and other Epic organizations provide access to a read-only application called Epic CareLink, which allows community practices that are not part of the organization access to patient records that they're treating. So if they're like the PCP or they're a consult like for cancer or an oncologist, they have the ability to log into Epic CareLink and they'll see the same documentation. They will see those domains that are set up as a risk domain or those that are green that are on low risk. They'll also be able to see if we've provided resources to that patient to follow up with. So that can be articulated to community practices that are not on Epic as part of the organization. Another thing that can also be done is Epic has a interoperability program called Care Everywhere. Care Everywhere allows us to connect with other Epic sites and other non-Epic sites through HISPs or Health Information Exchange Systems that allow CCDAs to come across from, say, a Cerner site or another Epic site into our instance of Epic, and we can either in that CCDA look at the social determinants of health if they're able to send it. But in the case of Epic to Epic organizations, we could actually map it, which is an initiative that we want to do in 2023. So the state of New Jersey has about 70 hospitals, and out of those 70 hospitals, I believe 45 or 46 of them will eventually be all on Epic. And those Epic EMRs can all talk to each other. So if we know one healthcare system is documenting SDOH and they're doing housing, we could map their housing answer in question to our housing answer in question, and we can discreetly pull that in through external data mapping into our EMR and present it to our operational groups that are using the clinical documentation to update it. And vice versa, we could work with that organization to send our information to them. So that is something that we are looking forward to doing in 2023 with some of our other healthcare systems on Epic in the state of New Jersey. But what all this does is we're trying to create uniform documentation. So we really want that uniform documentation that's following the patient through the longitudinal care so that, you know, an oncologist, a cancer navigator in our navigation team, an ACO care coordinator, or just a medical provider or an ED doctor are seeing the real-time updates that have been documented at each point of contact when that patient has come to our health system, because we know that the SDOH domains can create obstacles for better health and to improve quality outcomes. So we want to make sure that it's across the board for everybody. Next slide, please. So with that, we have our community resource directory, which is the list of all the different community resources in the state of New Jersey and in some areas of New York and Pennsylvania. And what we have done is we've actually loaded that directly into Epic. So we had initially partnered with NowPow, which is now part of Unite Us, and they were able to provide us a resource directory of over 10,000 locations in the area that we were able to load into Epic, and we mapped those to the domains. So what we do there is when you have a transportation issue, so to speak, that is a risk, when the end user goes into the community resource directory, based on the patient's zip code, it will geolocate the closest resources for transportation. That end user can then select any resources that they want to give to that patient, or they can collaborate with the patient for ones that make sense for them. And we can put it on their after visit summary. The beauty of having it on the after visit summary is it does two things. The first, it provides all the information about that resource. So it will provide their address, their phone number, email, website, if applicable, hours and days of service, languages that they speak, and if they're LGBTQ friendly organizations. The other thing is with our Epic MyChart patient portal, that also, the after visit summary goes into the MyChart portal. Because if you're anything like me and you get a bunch of paper printed out when you get discharged, you kind of toss it in the backseat of your car, but it'll always be on my mobile device for MyChart, or it'll be on my computer when I log into MyChart. So I'll always have the ability to look it up based on what they gave me before I left. We are currently working with Aunt Bertha now as a possible resource to get a compendium of community resources to load into our system quarterly. And we're kind of in the beginning talks about if there's a need to use them as a third party for any additional services that they might provide. And again, the whole point of this is that we want to make the visible clinical documentation available to all of our end users to assure that they know that whoever did that outreach and found a risk, that we have provided resources for that patient. And that again is visible in all of the areas that we have the tool for SDOH and Epic, so that storyboard section, the wheel in our longitudinal care plan, you will see right underneath it the resources that have been selected by the previous end users to give to that patient. So you can easily follow up with either that resource by contacting them or the patient in your next follow-up. Next slide, please. So one of the things that is a challenge for, I'm sure, all of us is how do we know the patient went to that resource and obtain the services that they need? So one of the biggest problems is you're going to hear a lot of closing the referral loop and, oh, we promise that we're going to be able to get that resource to go into the system and close your referral loop if you send them the referral. That is one of the biggest challenges that I think all of us have to overcome. There are various different ways that you can try to close that referral loop, but our success has been very minimal in our state. Even partnering with insurance carriers and certain community resources, we have not had success at all in getting those resources to log into our system or their system to speak to our system and let us know that the patient arrived. So we have pivoted to doing more follow-up. So with our cancer care navigators who are reaching out to patients that they are tracking for, anywhere from 12 to 18 months, we are asking them to consistently assess their SDOH needs, but also to go and follow up with that patient. Did they go get the resources that they were needed? So we have taken more of a point-to-point approach with the patient rather than the third-party vendors that are providing services. But we also have some groups that are actually outreaching specific resources directly by calling them up and asking if the person arrived, because they should be keeping records of that. So as that is being done, we're updating our clinical documentation so that our end users know, okay, that patient went to that resource and they received services, and hopefully we're changing the documentation that they no longer have that need anymore. And we're going from a red risk, to a green low risk. And that is really the path that we've taken right now. So we're always looking for new and innovative ways to try to automate that with our trading partners in the state for community resources. But again, as mentioned, we're finding very low success rates in that. Next slide, please. So one of the reasons that our organization picked Epic is because it has a very powerful reporting structure. And with that reporting structure, we're able to do all sorts of fun things with data that come into our system, not only from our clinical documentation, but I mentioned with our external documentation through CCDAs. So we have developed a dashboard for social determinants of health that assesses both adult and pediatric populations. We have broken down each domain with numerator and denominators, and then we built reports behind it so that we can go track those patients. And one of the first things that we noticed that we needed to get into that report were specific demographic information when we're looking at those domains. So of course, your name, your medical record number, but your age, gender, and specifically race, ethnicity, and language, we felt were very important to have on that report, because we know that if there's a language barrier and the person outreaching that patient cannot speak that language, there's going to be difficulty in ascertaining if the patient was able to get the resources necessary. We are also aware that different ethnic groups handle community resources or handle health in a different way. And we want to make sure that we're outreaching them in a specific manner so that we're being adherent to their ethnic specialties that may change or alter the way that we handle healthcare. When we have all that data, some of our ability is not just a static report. We have the ability to slice and dice that data. So we can take all of that data of our 675,000 patients, and we can drill into a zip code and say, we want this zip code, we want this type of race or this type of spoken language with this domain, and maybe even throw in a chronic condition or two in there. And we can drill into a population that has risk and decide to do a pilot for that group, and maybe outreach them specifically to do specific targeted outreaches to improve their quality of life. So Epic allows us to do all these fun reporting pieces on the fly if you have a hunch. And it's not even something that you have to ask our IT team to do. We teach you how to use it so that if you're just sitting and thinking, I think that this particular population has a need, you can go in and do that slice and dicing by yourself. And then you can present a possible program or pilot to your operational leaders, and then we can probably try to implement that. So our reporting structure is extremely robust, and we leverage it as much as we possibly can. Next slide, please. So all of this also leads into regulatory requirements. So CMS has just released a final ruling that there is a health equity measure for 2024 that will be mandatory for hospitals and medical groups concerning social determinants of health collection. And we know NCQA is going to be right on their heels with their HEDIS measures. So part of what we did was we were looking at that particular idea to standardize our documentation with an approved tool that has been nationally recognized. And that's why we went with the AAFP, American Association of Family Practitioners SDOH tool. But internally, the state of New Jersey has the NJKIP program. Some of you may have heard of DISRIP. If you have heard of DISRIP before, DISRIP went away. Each state is now doing their own Medicaid programs. And the state of New Jersey wanted us to use a standardized tool for our behavioral health and maternity patients that are on Medicaid. And that's why we came to the consensus to go with the AAFP tool, not just for that group, but as the standard process, knowing that CMS and NCQA in the future were going to be doing these regulatory measures. So because of that, we implemented that, I believe, in May of this past year, and we've had a high success rate of documenting that information. And we've already seen our KIP population is already ticked up. So we met our 15% increase threshold for the year, which is fantastic. And we're hoping to get way higher by the end of the year, although there's only 2 months left. But we'll do the best we can. We only implemented it midway through the year. But with all of that, our governance committee decided that NCQA is doing their first health equity accreditation, and we are pursuing that accreditation. It is a two-phased accreditation. The first phase is that we are a equitable organization when it comes to not just our patients, but with our staff and employees, and how we're training health equity, training social determinants of health, and how we're doing our hiring process. But the second phase of that is actually very key on social determinants of health. So having this standardized documentation, this enterprise solution that has been accepted by our operational leaders, is putting us on a track to fast track both phase 1 and phase 2 early of 2023, so that we have the accreditation. Hopefully, we'll be one of the first organizations in the country to have that accreditation. So that is how we are currently tackling SDOH, and that all fits into our cancer navigation, because our cancer navigators really benefit from having access to a standardized tool that is being updated across our longitudinal care, and they're able to not only see all of that SDOH documentation being completed on their navigation patients, but they're also to actively participate in updating that documentation to not only help the patient, but to help all of our clinical end users in that patient's journey. And I tried to talk slow. So I guess we can open it up to any questions that anybody has.
So while we wait for some questions to load in the question and answer section, Jeffrey, I would like to revisit a discussion that you and I had previously about communicating with partners who are not on the Epic system. I know you touched on that a little bit during your presentation, but we have some Alliance members who will be partnering with community members who do not have that as their EMR system. So if you could go into a little bit more detail and discussion about what that would look like, we would appreciate that.
Sure. So Epic has the ability to provide Epic CareLink to any community practice, or even any other healthcare system for that matter, who want access to patient records within our own instance of Epic. That is just simply reaching out to the IT team and asking for CareLink access. The process varies on how you get that access. But once you have it, you're able to look up patients that you have an attribution to. Typically, if you're the PCP for the patient, if you're a consulting provider, or if you have any other type of attribution, like you saw the patient in the hospital, you can look the patient up manually in the system, depending on the requirements that each organization puts down for you to be able to look up that patient. Some are more stringent than others. So it's not just the name. You may need like their social security number or their telephone number or something like that. But once you get Epic CareLink access, not only do you have access to the patient's record, you have access to their SDOH documentation. So each organization sets up Link a little bit differently, but typically there's always the longitudinal care plan, which will have that social determinants of health wheel in it. You can't document on it, but you can at least see the latest documentation. You can see how it's trended over time, and you can see if they provided any community resources for that patient. Plus, you can look at any documentation that have been done on the patient, like say for like our care navigators, their notes would actually be part of the note section. And so if you wanted to read up on how they were addressing that need, if it was part of their documentation, you'd be able to see all that information as well.
So we have a few questions that have been posted in the question and answer section. Remember, if you have any questions, please post them in there. So first question, could you expound on the new social determinants of health requirements for 2024?
Oh, absolutely, because I just got this email from our VP of Quality yesterday. And I mean yesterday while I was watching football. She sent it out. So CMS is going to have a population 1, population 2 requirements. They're looking at 5 domains. They're looking at food insecurity, housing instability, transportation needs, utility difficulty, and interpersonal safety. Population 1 is they're looking at all patients admitted to a hospital and how many did you screen for SDOH. So the denominator is anyone 18 and older that has been seen in your facility, and your numerator are anyone that has been screened. Population 2 is all patients admitted to the hospital who receive screening and were identified as having one or more social risk factor. So that denominator will be all patients admitted to the hospital 18 and older and screened. And then the numerator is patients who are screened positive for any of the 5 domains. The way I take that second piece is if anyone has ever dealt with glyco-A1C, it's an inverse measure. So the higher your numerator, the worse you're off. So you want to be 1%, not 100% on SDOH 2 population. SDOH 1 population, you want to be 100% because you want to be able to screen everyone, but you want the second one to be lower because it's an inverse measure. We don't want people to have a risk. And I would assume if you know anything about CMS versus HEDIS, it'll be very similar. With probably one slight difference. Maybe they'll have a different domain in there, but they're always a little different, which is part of your stewardship problem, is that the measures never really 100% align across organizations.
Next question. For agencies without Epic, is there a way for client navigators to enter information and notes into the system?
Well, I guess it depends on where you're working on it. If you're working in a healthcare organization that has an EMR, you should be able to do your documentation in there, whether it be Cerner or Allscripts or Meditech. They should be able to set up a workflow that you could utilize the system to document your information as a navigator. Every organization does it a little bit differently, but I know here, at least within Epic and our organization, we make it mandatory. We don't want anyone on paper, and we don't want anyone in a disparate system that is not connected to us, and we try to put everyone on Epic.
How has this initiative been received by your providers, and what level of uptake have you seen?
So our providers love the idea of documenting SDOH in the system and understanding what those risk factors are, but our doctors don't want to do it. So we put that on our ancillary staff. So for instance, in like, I'll go through the different areas. So in the ED, it's part of triage. So it's a requirement in triage to ask those 5 domains. Inpatient nursing, we've made it part of the admission documentation. So the mandatory 24-hour admission documentation that a nurse has to collect. But we actually split it. We only want the nurse to collect the information, but we want our social workers to do the follow-up for the resources prior to discharge. So on the inpatient side, the nurses didn't want to do the full thing. They wanted to split it, and it was agreeable by both parties. On the outpatient side, for our medical group, it is part of our rooming process. So when you're collecting medical, surgical, and family history, we have social determinants of health as part of the history, and that is mandatory. So that is done in every rooming session. When it comes to cancer navigation or our ACO care coordinators or our Institute for Prevention and Recovery folks, it's embedded as part of their normal workflow. 9 out of 10 times we have what's called a target, which populates on their dashboard as something that they're required to do within a certain cadence of time. And that target will keep populating, and then it will say it's overdue finally until they collect that information and close that target out.
So this sounds like it was a complete policy change within your organization. So it wasn't
Yes.
a lot of options in that, huh?
No, the only group that we've had, and I'll be transparent. The only group we've had a problem with is our behavioral health folks. More so because a lot of their tools that they use to collect similar information isn't a one-to-one match, and unfortunately, due to regulatory reporting, we've had to sort of, as you put it, there wasn't really much of a choice. You just have to do it because we are beholden to our regulatory groups.
Next question. Can you talk more about the process of pulling data from Epic? And two-part. Does IT at your institution manage those data pulls for you, or do you know if an individual provider team can do so?
So Epic has three methods of actually doing data reporting. The first is the IT team will create reports, and we try sometimes to create the reports for standardization, but most of the time we kind of give the power to the end user, and that again was one of the reasons why Epic was such a powerful tool for reporting. So end users, depending on your organization, our organization requires them to go to 2 reporting classes to get a super reporting template, and they can create what's called a reporting workbench report. They kind of have to know what they're looking for in order to do it, and it can get a little tricky with some of the criteria. But some of them become quite savvy at it, and they create all sorts of fun reports. Then when they break it, we get a ticket and we look at it and go, "What the heck did you do?" And then we have to fix it and then kind of show them what to do. The slicer dicer model, which was the hunch one that I had mentioned earlier, that allows you to just kind of like plug and play. There's just what's your measure, what's your population, what's your criteria. You can pick from a list of things, and it kind of pulls in that population. One thing I really like about the slicer dicer and Epic is it also has a map in there. So if you, instead of looking at like a pie chart or like a graph, you can actually pick the geolocation, and it'll actually show a map of your area, and it will highlight areas in color depending on the population. So you can drill into a town or a zip code and kind of see that population, so you can see where the hotspots are. But those two are for our end users to use, and we typically try to show them how to use it. IT will create more robust reports. Most of the time, that's with the external data I was talking about, where we're getting things from CCDAs, or we might be loading a lot of data from like our payers into our database. That's where the IT team has to write those reports. And so like that dashboard I was talking about, that has to be an IT dashboard. It has to be an IT report behind it, because we're pulling all sorts of different information from all over the place, and we want to validate that we're pulling the right information. So there's 3 levels. It all depends on what you're looking for and how robust of the data you're looking for to be.
Could you say more about using the storyboard in Epic? Is it
Yep.
standard in Epic?
Yeah. So different EMRs call it different things. It might be like the patient banner. Epic had a patient banner that went across the top. And then what they did is they switched it to a storyboard. The storyboard in Epic is it can be specific by the end user that is logging in. So there's like a cardiology storyboard versus a medical group's, primary care storyboard versus an inpatient nursing storyboard, an outpatient nursing storyboard. And what we want to do is we want to display very specific information for what that particular person is doing. So a cardiologist doesn't really care about the last A1C. They want to see the troponins. They want to see the CK and MB. They want to see the last echo that was done. But there are certain areas within that storyboard that we can override and make it a mandatory area that must be displayed. Things like that are like if you have COVID, or if you have if you're intubated, or if you're a DNR, or if you have SDOH domains. And so we've made it a requirement that SDOH is in the storyboard. And it took some fights. Some people wanted it way down at the bottom where they would never scroll to, but recently we won the battle to move it way up and make it very prominent, like underneath their insurance. So it is always visible. So within Epic, we were able to do that. I don't know how other EMRs are able to customize their patient banners and if they're able to put things like that in there, but it is something you could explore.
How long does it typically take to onboard new navigators to understand and use the Epic system?
Well, that is a loaded question, and I would need to so defer to our operational users. Um, in practice, I always tell people Epic training is, depending on what you do, it can be long. It could be 4, 6, 8, maybe even 10 hours worth of training. Epic has a lot of information in it, and there's a lot of things that you need to know how to do in Epic. Typically, my experience has been that when you have a new onboarding end user, the first 2 to 3 months, they're going to be very frustrated. But about 6 months into their time on Epic, they'll laugh at the first 3 months because then it just becomes intuitive. So it all depends on how quickly you can pick up navigating through an EMR, but also making sure, and I say this, and I don't care what EMR you're on, you got to follow the instructions on how to do the documentation the way that you're taught. Because if you try to make workarounds or you try to cut corners, you can really blow out a lot of those reports we were talking about, and we're not collecting things the correct way. So whether it's Epic or Cerner or anything else, always follow the training that's been given to you. Don't create shortcuts, but any system is going to take, time for the end user to remember everything that they were taught and what they have to do.
Is there a list of tracking systems that work best with Epic? Oh, my question went away. Hold on one second.
I think I remember that for like non-Epic organizations. Not really. I mean, unfortunately, everybody has their own flavor, so you really can't say there's one that's better than another. I'd say that anything that integrates with Epic is better because they've at least taken the time to work with Epic systems to come up with a method for at least transmitting some sort of information back and forth. So I would just say, if they have a connection to Epic, that's better than not having a connection to Epic. But I would, if you are an Epic site, I would scrutinize. I would definitely have your IT team on there and scrutinize that vendor because I've come across a lot of vendors that promise the world and I get a cupcake and it doesn't work. So NowPow is one of those. So
Could you provide further details on the process it took to load the outside social determinants of health directory into Epic?
So actually, it was fairly simple. Both Amperth and NowPow have an Epic import spec that they generate. Really, what it came down to is mapping the domains appropriately and then cutting out ones we didn't need because the resource directory they give you is going to have like nursing homes on it and PT sites and things like that that you don't need that information. So we worked with our operational team to kind of go through that list and we kind of broke it down. And I think it took like 2 or 3 weeks to cut the list to the correct services that we cared about to load. And then I think it took like 3 or 4 days to just map it to the domain. And then loading it takes about 10 seconds. Then you want to test it, of course. So however you're going to go about your testing process or what your change control process is, that might take a week or two. And then you load it into production. So overall, I'd probably say 2 total months to do the initial load. But once that initial load is done, subsequent loads take seconds.
So I have an additional question that hasn't been posted. If you could, Jeffrey, provide just like an overview of your 3 biggest challenges and how did you address those challenges?
3 biggest challenges. The first was universal documentation across the health system, because to be fair, we are not all on Epic yet. We are in the onboarding process to all of our sites. We have, by the end of next year, all but one hospital will be on Epic. Our entire medical group is on Epic. Our cancer, CINJ Cancer Institute of New Jersey is on Epic. So that makes that part easy. It's the hospitals that are a little trickier. But that was the first challenge, was getting everyone on Epic, but then getting the standardized tool. The standardized tool was the second challenge because there were disagreements between different groups like behavioral health, pediatrics, and adult who thought that there were different domains or different questions that should be asked. When it came down to mitigating the tool, when regulatory requirements came in, that's usually where you can get everyone to step aside. We are still having a slight challenge with our behavioral health group, but we're working through that, and we're not going to change what we're doing. They're just going to accept it. It's just how in the workflow do they incorporate it. And then our third major challenge is the follow-ups. It's, did the patient get the resource? And that's a challenge operationally because you have to have buy-in from your operational teams that they're going to do those follow-ups. Because if we can't get that referral loop closure, from that resource, we need to be able to find a way to follow up with the patient. I've been an advocate that collecting SDOH is half the battle. It's making sure that they actually follow through with the resource that wins the battle. So you want to win the whole war. You don't want to win a few battles here and there. So I advocate constantly for follow-up because it's the only true way that we're going to be able to get that loop closed. And Jeannie, thank you so much. I just want to read the follow-up from Jeannie from our organization. Bless you for being on here. She said that the RWJ navigators take a social care track class, and then they have a super user that does one-on-one training sessions to document the SDOH navigation and counter template. So for the person that was asking about how they quickly they pick up the using the system. Jeannie's team actually, we all have super users in all of our areas, to be fair, and Jeannie's team is really good at using their super users for extra one-on-one training sessions. Thank you, Jeannie.
Is the services directory, along with the filtering by proximity to the patient, a built-in Epic function?
Yes, it is. So the community resource directory is a foundation build that comes with Epic. It's really, as I said, doing the mapping process once you get your community resource directory in there. And if you do have one from like a NowPower Amp Bertha where it has an Epic import spec, it's very intuitive for the end user when they open up the community resource directory to see it. The best way that I can correlate it is if you have ever done a referral or you've ever looked for a next site of care like a nursing home, it's the same section. It's no different than looking up a doctor or a next site of care.
So while we wait for a couple more questions to be loaded in the chat, Jeffrey, can you go into detail about how you were able to work with your senior leadership to get them on board with some of the changes, and how you were able to push forward with moving those social determinants of health up in the portal?
Yep. So what we decided was, as an organization, we needed a governance committee that was going to be the be-all, end-all of SDOH. And we wanted to make sure we had the right group of people together. So we wanted to make sure our regulatory folks were there. We also wanted to make sure that we had representation from various areas of clinical and non-clinical. So we wanted, case management there. We wanted nursing leadership there, physician leadership there. We also wanted health information. So our HIM folks to be there. We wanted our, so we have an area called Ending Racism. So our Ending Racism group, we wanted their VP to be there to, have their input. And we also want IT there because we want to make sure that whatever decisions you're making, and I'm a proponent of this across the board, if you're making an operational decision on a workflow, IT should always be present before you make that decision because we can tell you what you can and can't do. And that can alter dramatically what it is that you're trying to accomplish. And we always try to make sure that we're fitting your need, that you're not fitting our need, because we want to be flexible for you. And that's also an advantage of Epic is that your own organization, your own team does all the build. Epic does nothing. We only go to Epic if we have a problem. But everything that is done in Epic is done by your actual IT team, and every request that goes in is straight to people that work in your organization. So when we decided to come up with that committee, we wanted to make sure, like I said, we were addressing all areas, and we wanted to make sure that we had their senior leaders on board so that the communication can trickle down, so that they know that this wasn't just, a whimsical decision, that this was thought through. Everyone was voicing their opinion, voicing what they thought the best workflows were, and then partnering with IT to make sure that what we built would actually meet that need. Did I answer your question?
Are the Epic super users employees of your health system?
Yes, 100%.
Do all care team members receive training on Epic social determinants of health use?
Yes, in two different ways. One, they are trained in their training classes, but we also, as part of that NCQA accreditation, we have mandatory training for all employees in our organization on health equity and social determinants of health.
What's been the response of patients?
We don't have a survey to ask our patients that question, so I actually can't answer it. But that is something that we should consider putting in place as part of our HCAPs and putting it in one of those questionnaires. I'm going to steal that one from that anonymous person. Thank you so much.
Were there specific goals that you adopted for ending racism in oncology?
I know Jeannie's on, so if she could type an answer, I would bless her. Ending racism as a whole is more about education. So from the oncology perspective, part of their required net learning training that we do annually is on ending racism. So for the adoption of it, everyone has to go through health equity and racism training, so that we are mindful of how we are treating not only our patients but ourselves. So that automatically happens. So I think within the context of that, because our VP of ending racism is a big proponent on making sure that we're treating everyone the same and giving equitable care, but also removing stigma and bias from conversation, I think falls under oncology and how they are adopting it.
Jeffrey, can you go into a little bit more detail about other e-referral platforms that can be interfaced with Epic?
Sure. So right now, the only one that I know that has a very good relationship with interfacing with Epic is Aunt Bertha. Aunt Bertha, the founder of Aunt Bertha, he was an architect at Epic. And when he was creating the platform, he's been the whole time working very tightly with Epic. So there is some robust integration there. It depends on how you want to use it. Now, POW also had some pretty robust integration with Epic, but when they were purchased by Unitas removed that integration and they're trying to develop their own. So in a way, they kind of went a little bit backwards, which is one reason why we're not pursuing Unitas right now, because they're behind Aunt Bertha. They're the only three that I was really well aware of that were in this space. And I know Aunt Bertha is right now the only one that really integrates with Epic.
Are you also collecting sexual orientation and gender identity data? And if so, how is that used to ensure that a patient is connected to a service that will meet their unique needs in a safe and supportive way?
Yes, we do. I'm not going to get them all right. I have to think about this off the top of my head. We have legal gender. We have patient identified gender. We have oh god, there's four of them. The medical gender, and then there's I forget the fourth one. But we also have a in organ inventory as well for the provider to complete, so that we are aware of what the patient identifies as their legal sex, if they have changed their sex, how they identify within their sex, and I forget the fourth one. I can look it up and respond later. But then we also do the organ inventory, because the organ inventory is important when it comes to treatment. So our physician population has been trained when these are obtained, how you're supposed to handle that patient. And we do have, I know at least at one of our facilities, we do have a very specific outpatient practice that only deals with those types of patients that answer outside of being straight male or straight female. And I forget the name of that practice, but it's a very big practice. They get patients from New York, from Delaware, from Maryland, from Pennsylvania, even as far as Ohio, that come specifically to that office for care. So our organization is very big on that, and we have a very tight relationship with our LGBTQ community, and we are very supportive of all that. So we want to make sure that we're collecting that data every single time, and that we're caring for our patients appropriately based on what their responses are.
Sticking with my theme of three, Jeffrey, can you provide us with three of your top priorities that you feel like is necessary to properly integrate the social determinants of health metrics into your EPIC program?
So the first is that we're making sure that we're addressing those needs. We want to make sure that none of our patients have risk. And I know that's a tall glass to fill, but wherever we can impact our patients and reduce risk is our priority as a healthcare organization in general. The next two are, I am a strong believer that our quality measures that we are attributed to both through our insurance contracts and our ACO and through CMS have great impact when it comes to SDOH. And I feel that if we can mitigate SDOH risks, we can improve those quality measures, and in turn, we're improving quality of life. And the third one is we want to make sure that our communities trust us. We know that there is a lot of distrust in communities with healthcare organizations, and we want to make sure that when we're addressing SDOH, we're addressing it from a community perspective, because we want to make sure that they understand that as stakeholders, we're not just a healthcare organization, we're community members ourselves, and we want to make sure that we're all getting our SDOH needs mitigated and that we're all improving our quality of life.
I'm going to take a second to see if there are any additional questions.
Sure.
Jeannie just posted a follow-up. I'm going to read it. The navigation program aligns with the system's goals for ending racism. Navigation measures 27 barriers to care and has expanded the assessment to include the system's social determinants of health measures and EPIC template. Aligning barriers ensures visibility and removes duplication of efforts. Thank you for that follow-up. Are there any more questions? So we have roughly about 14 minutes remaining in our webinar. Before we end, Jeffrey, I would like to take some time for you to just add anything additional that you would like for our Alliance team. Hold on. Okay, sorry. If there's anything else that you would like to add before we close out for today.
I think just making sure that each organization is, looking across all your clinical areas when you're addressing SDOH and not try to force it upon each group. And we learned that trying to force it on groups was a barrier, but when we incorporated everybody into the discussion, that's where we had the least amount of resistance. So as you're trying to determine the path that you're going to go, I don't think it really matters, if you're going to use a third-party vendor or not, but I think that, having a standardized tool and having everybody involved in the conversation at your leadership levels that can agree on how to implement it is probably the best method to go, regardless, like I said, of the EMR or a third-party vendor, because you need the buy-in from your operation leadership so that they can get the buy-in from all your end users. And that's really the way to move forward in incorporating SDOH as part of the clinical journey for the patient.
So it looks like there are no additional questions. We just want to thank you, Jeffrey, for taking time to speak with our Alliance about EPIC. I feel like I definitely have learned a lot through your presentation, and I'm sure that the Alliance members probably feel the same way. We're looking forward to meeting with you guys in the next couple of weeks for your monthly Alliance meeting. Which will be happening on your scheduled date on Tuesday. Likewise, as we prepare for those meetings, please make sure that you have
Dr. Wright, you're going in and out of being on mute.
Oh, wow. Sorry about that. Please make sure that you have your work plan, because we're going to revisit that to make sure that we are all addressing or have addressed our quarterly one goals as described in the work plan. So if there are no additional questions or concerns, again, thank you, Jeffrey, for an amazing presentation, and we will close out for today.
Not a problem. Happy to